am so pleased to welcome to the podcast Avik Roy, here in person in our studio at KFF. Avik is co-founder and chairman of the Foundation for Research on Equal Opportunity, which studies and recommends social policies for the half of the population that earns less than the U.S. median. But he's also a longtime health policy wonk and a health advisor to Republicans, including several Republican presidential candidates over the years. And full disclosure, he is, like me, a fellow Michigan Wolverines fan. Avik, welcome to What the Health.
It's great to see you, Julie.
So, how did you come to health policy? It was a bit of a winding road, wasn't it?
Yeah, I kind of fell into it. I was working as a healthcare investor, actually at Bain Capital and a couple other places like that. And as a healthcare investor in 2008, Obama gets elected and starts to talk about what we now call the Affordable Care Act or Obamacare. And what I wasn't reading anything I agreed with. At that time, Ezra Klein then at the Washington Post, and you had Jonathan Cohn at the New Republic, and you had that group of young bloggers who were writing about, hey, there's this brilliant MIT economist named Jonathan Gruber, and he's got it all figured out, and everything's going to work great, and premiums are going to go down, and Obama himself promised that premiums for the average family of four would decline by $2,500 per year. That's what he campaigned on in 2008. Then on the conservative side, you had a lot of people writing things like, it's big government, it's unconstitutional, it's welfare. And I found these arguments kind of like empty calories, because for the average American who's struggling to afford health insurance and health care, I just don't see how that person is going to respond to that kind of argument. They're going to be like, look, if one side is telling me they're going to reduce my premiums by $2,500 per family per year, and the other side is just saying, ignore this all because it's big government, which side is the average person going to choose? They're going to choose the side that's going to try to reduce their health care bills. And my point of view was not aligned with either of those positions. My point of view was actually healthcare bills are going to continue to increase, and the design of the ACA has a number of flaws that are not being called out because the conservative critics just weren't digging into the technical design, the architecture of the bill. And even though I'm not as eminent as Jonathan Gruber, I did go to MIT, and so I maybe felt a little more willing to engage in that debate.
And you're a doctor.
Well, I went to med school. I never practiced, don't have a license.
But you have at least the medical education, so you have a good bit of background in this. So I want to sort of think broadly. Every other developed country has some sort of national health insurance scheme. Most of them are hybrids of public and private. Some of them more public, some of them more private. Why hasn't the U.S. been able to solve this problem that every other developed country has?
Well, we actually do a lot of work on this at the Foundation for Research on Equal Opportunity. We have a whole annual research product we put out called the World Index of Healthcare Innovation, where we compare 32 countries around the world with the highest GDP per capita that have a population over 5 million on quality, choice, science and technology, and fiscal sustainability. So a number of other people do these kinds of comparisons, but our study is different for two reasons. One, we don't just look at OECD countries, which is typically where most academics get their data. We look at countries that are outside the OECD, particularly in Asia. And we also, again, score countries not merely on health outcomes and equity-type measures, but we also look at things like fiscal sustainability, which we think matters for long-term equity, and science and technology. One of the defenses of the American system that you always hear is, well, yes, our system is so expensive, but we're also the innovation center of the world, and you can't have one without the other. So one thing that we wanted to study was, is that really true? Can you actually have more innovation? Can you have innovation at a U.S.-like level, but with a universal system that covers everybody and has good quality? And the system that ranks number one in our study, has ranked number one in our study every year, is Switzerland. And the reason that's really interesting is because there's a misconception both on the left and the right that to achieve universal health insurance, you have to have a single-payer system. And that's not actually true. There are plenty of countries, there are a minority of the industrialized countries, but it's a robust and significant minority that have achieved universal coverage using private insurance, not necessarily a single-payer government-run insurer. And Switzerland is, in our view, the best example of that, because Switzerland is a place where there's an innovative pharmaceutical and biotech and med devices ecosystem. They have universal coverage. It's basically like Medicare Advantage for all or Obamacare for all. It's a universal individual market where the market is regulated and subsidized.
I was going to say big subsidies. I've been to Switzerland. I've studied the Swiss healthcare system.
It's big subsidies. It depends on your vantage point. Relative to the American system, the subsidies are actually quite low. So what Switzerland spends subsidizing healthcare is about 45% of what the U.S. spends per capita subsidizing healthcare. We actually subsidize healthcare per capita more than any other country in the world because the cost of healthcare is so high in America that the cost of subsidizing healthcare is so high.
Which was going to be my second point about Switzerland, is that it's way more regulated than a lot of Republicans think.
Well, it's about as regulated as Medicare Advantage or the ACA plans in terms of the insurance plan design. There are other things, and we don't have to spend all of our time on Switzerland here, but the reason you asked the question is like, why can't we do this in America? That was your original question, and there's a number of reasons for that. One is path dependence. With any healthcare system, once you've established it, it's hard to change. And the two things, the one thing I will say that we did in the mid-20th century that really put us on this path was when we excluded from taxation employer-sponsored insurance, because in World War II there were wage and price controls. Employers figured out how to get around that by offering employer-sponsored insurance that wasn't regulated by wage and price controls. And then after the war, Eisenhower said, "Yeah, let's not tax those insurance policies because they seem to be important for people." And it was kind of an offhanded decision. No one really knew that was going to be this big thing. But sure enough, 80 years later or 70 years later, here we are. And I would argue that's the biggest driver of healthcare inflation, because we don't merely have third-party payment for healthcare. Every country has third-party payment for healthcare. But we have third-party payment of third-party payment of healthcare. We have ninth-party payment of healthcare, basically. And no wonder that no one has any sense of why everything is so expensive. But that's the core driver. And unfortunately, Medicare in particular built on that system. When the Medicare law was passed in 1965, a key element of Medicare was to build upon and drive the benefits based on the traditional Blue Cross employer-based plan, which had by that point already ballooned into something resembling what we have now.
So why has healthcare been such a low priority for Republicans? I always hear, well, Republicans don't really work on this because it's not important to their voters. That can't possibly be true anymore.
I think everything you said is just right. I think that historically, Republicans didn't feel that it was relevant to their voters. Their voters weren't really pushing for it because their voters were, relative to the median constituent, perhaps more likely to be employed or more likely to be on Medicare, and therefore didn't feel like they had to worry about affordability. But affordability, as everybody at KFF knows and the audience that listens to your program knows, affordability is a big deal for everyone. Premiums in the employer-sponsored market have gone up, and people don't necessarily notice that, but they notice that their paychecks have been flat. They notice their deductibles going up and their copays going up, and that's been a big problem both in the ACA markets and the employer market. But affordability is a big deal, and now that the Trump GOP has become more of a working man and woman's party, and you see it in all the exit polls, that if you actually look at who's voting for Democrats and who's voting Republicans in presidential election years, the Republican electorate is now a bit more lower income than the Democratic constituency, which has a lot more of those college grads and grad school grads. I think you're starting to see more of that populist concern about the affordability of health care. But there's still an enormous amount of intellectual catch-up to get there. And you started with, how did you end up in this space? I was just a guy who had a bunch of opinions and didn't feel like I saw them being represented, so I started a blog. And next thing you know, it kind of took off because no one else was making those exact arguments. And I started getting invited to blog at Forbes and National Review, and then I became the opinion editor at Forbes, and then we then called it the policy editor, and then a think tank in New York called the Manhattan Institute asked me to become a senior fellow there? I'm like, I have a day job. I can't be a senior fellow. And they're like, no, that's okay. Just put senior fellow at the bottom of your blog post and we'll pay you. I'm like, really? That's how...
Seriously, you could fit all the Republican healthcare wonks around one table for a long time.
We joke about that morbidly sometimes, as if someone bombed that conference room, it would be a big problem. But it's also like herding cats. We often disagree with each other. I think I have been, because of this experience of studying the international healthcare world, I've been much more optimistic about the ability to achieve universal coverage in a way that's friendly to free marketeers, people who believe in private sector competition. Whereas I think the traditional Republican view, which you kind of alluded to earlier, and I ran into this a lot in the 2017 repeal and replace debate, was it's not the federal government's job to ensure that everybody has affordable health insurance. That's what I heard from a lot of the kind of old line Republicans and Republican staffers in the 2010s. It's not the government's job, not the federal government's job to guarantee affordable health insurance for people. That should be up to ordinary people to make enough money to afford health insurance. And I disagree with that very strongly. And the reason I disagree with that very strongly is because it was the federal government that screwed it up in the first place. It was the tax exclusion for employer-sponsored insurance and then some of the things around the design of Medicare that drive all the healthcare inflation that we've seen over the last 80 years. So the federal government created the mess, and it is the federal government's job to clean up the mess. And I guess you could say a big purpose of my work is to try to convince more Republicans to agree with me on that.
So why has it been so hard for Republicans to come together on anything? The Democrats have big divisions, too, on health care. They, have a big chunk of Democrats who would like Medicare for all and another chunk of Democrats who would like to build on the existing system. Republicans presumably have the same kinds of divisions, just in the other direction. And yet we almost never see Republican proposals, and we do see Democratic proposals.
Well, I will quibble with you a little bit, Julie, in that there are Republican proposals. They don't always get the same amount of media coverage that the Democratic proposals get. There is a bill that's been introduced in both the House and the Senate based on our work at FREOP called the Fair Care Act, which would achieve voluntary universal coverage. It wouldn't force anyone to buy coverage, but everyone who wants to buy health insurance would be guaranteed to have an affordable option. It would reduce the deficit, increase coverage by about 9 to 10 million, and also reduce federal spending. It would reduce taxes and reduce federal spending because it would reduce the underlying cost of health care.
How?
By in particular tackling the power of hospital monopolies and being more aggressive about high drug prices. And it would also means test the subsidies. And by means testing, I don't just mean means testing Medicare, which is often what people talk about, but also means testing the employer tax break for health insurance, for example. And really having...
So more like Switzerland.
Exactly. So this all these random digressions that I've been coming with, there is actually a coherent idea here that I'm trying to get to. And I thank you for reminding me of that. So the beauty of the Swiss system and the reason why they spend less than half of what we spend subsidizing health insurance is because they have, like the ACA, in fact, the ACA was kind of modeled after Switzerland, they have this sliding scale of subsidies which gradually phases down as your income goes up. And but they don't just have that for the ACA-style population. They have that for everyone. So it's a universal, individually purchased or non-group health insurance market. So there's no Medicare, no Medicaid, no employer-based market. There's basically, in a sense, you could say Obamacare for all.
And then they have sort of a Medigap on top of it. You can buy extra insurance if you want.
You can buy extra insurance if you want. And they do a lot, by the way, particularly at the cantonal, which is the equivalent of their states, their cantonal level, to negotiate hospital prices and drug prices and things like that. So they do a lot of things. They're very unsentimental about monopoly power, which is something I wish we had more of. And I kind of align myself with the Lena Khan types maybe a little bit on that front in terms of it's really important to tackle monopoly power in healthcare in particular. So all this to say that the Fair Care Act, the reform plan that was introduced, the most recent version was introduced in the House by Bruce Westerman, who's now chairman of the Natural Resources Committee in the House, and Jim Banks, who was then a House member, head of the Republican Study Committee, an important policy committee in the House for House Republicans. He's now the senator from Indiana, and it was or a senator from Indiana, and it was introduced in 2020 in the Senate by another Indiana named Mike Braun, who's now the governor of Indiana. So Jim Banks went to take Mike Braun's place. So a number of legislators are working on reintroducing that bill, and I would love to see more attention be shown to that bill, because when everyone says, "Oh, there's no Republican plan," there have been plans introduced by Republicans. Now, that's not to say like every Republican is endorsing that plan, but to say no one has proposed anything is not true. There are plans that have been proposed.
Well, I will say a lot of the ideas that we're seeing are, some of them date back to the 1990s.
Sure.
This is not the same healthcare system that we had in the 1990s.
Sure. So the Fair Care Act, I think one of the things that I would say is one of its merits is that it tries to tackle the problems of today. It's not merely a recycling of ideas from a long time ago. And really that the model is Switzerland. The idea is, for example, you can merge the Medicaid able-bodied population and the exchanges. There's no reason why when someone has 110% of income of 100% their income is 110% of the federal poverty level one month and 90% of the federal poverty level the next month, they should have to switch insurance plans and switch provider networks and not know if their primary care doctor is covered and all the kind of nonsense that goes on. I know KFF has written about this over the years. Same with the employer market. Wouldn't it be nice if instead of being handed a piece of paper by your employer, you have the agency to take those dollars and shop for the coverage that's best for you? So there are ways to bring all that together and gradually over time, over a 10, 20, 30-year period, take this gamish of a healthcare system we have with different health insurance systems for different kinds of people and have a more integrated system where you can keep your plan as you change jobs or get older or your income goes up or down.
We're going to see this in the next 3 months when Republicans insist they're going to come up with a fix?
Well, I'd say two things. One, as everyone who works in health reform, toils away in health reform knows, is you toil away in the basement with fluorescent lighting for years and years and years, and then there comes a point where the window is open for people to do health reform, and you have to be ready with those very well thought through ideas at that moment. So I think a lot of work in health reform, and frankly, in a lot of the work we do at FreeOp, is to do that hard diligence ahead of time so that when the moment comes where there really is interest in the reform, you've got a well thought out plan that can address the counter arguments and the concerns and the edge cases and all the kinds of things that you really have to do to be a professional at healthcare reform.
Any chance for bipartisanship?
I do think so. I mean, our plan is designed for that. In fact, that's when Bruce Westerman came to me in 2017 at the tail end of the repeal and replace disaster. And he said to me, "Avik, I'd like to come up with a bipartisan health reform plan." And I said, "Well, sir, that's kind of hard." And he said, "Yes, I do, but I want to do it because I think it's important." And I said, "Well, here's something I'll pitch you on. My theory is you'll never have a bipartisan health care bill unless it's at least equal to and ideally greater than the status quo in terms of the number of people who have health insurance, because no Democrat's going to vote for a plan that results in fewer people having health insurance. And you should also have something that reduces the deficit and without raising taxes to attract the Republicans. And if you could do those two things at the same time, reduce the deficit without raising taxes and increase coverage, then that's the only way to have a bill that can really be bipartisan. And that, of course, doesn't guarantee success, but I would say that's the sine qua non of having success. And he's like, "Great, can you send me some bullets?" And that started a now 8-year-long relationship where we've built real legislation that contains a lot of these ideas. And to go back to your earlier question, which is what can we do in the next 3 months, I put out an op-ed in the Washington Post a couple months back during the shutdown saying there is a way to come to a bipartisan solution on these enhanced ACA subsidies that were enacted when Biden was president. And my argument is, let's basically take a tiny bite from this larger cookie of the Fair Care Act. The tiny bite being, in fact, in the Fair Care Act, we talk about and we propose increasing the income threshold for ACA subsidies to 600% of FPL from 400% today, which I don't remember the exact federal poverty levels stats today, but let's say if the federal poverty level for childless adult is $18,000, maybe 600% of that is, what is that, $108,000? 400% would be $72,000 for a childless adult. So those are some of the numbers that we're talking about here. So in this proposal in the Washington Post that I put out, my thought was Democrats want to permanently extend these enhanced subsidies, which Republicans are very against, in my view, for good reason. We can get into that if you want. But it's something that Democrats really care about. Republicans say they care about the high cost of Obamacare-based insurance and the fact that, that high cost is increasing over time, that the premiums and deductibles have risen dramatically since the ACA was enacted in 2010 and implemented in 2014. And so my pitch is if you talk to insurance pros, if you talk to actuaries, what they'll tell you is the two biggest distortions in the ACA from a standpoint of how they price the plans are that, to put it very simply, Obamacare overcharges healthy uninsured people to make insurance affordable for sick uninsured people, and it overcharges young uninsured people to pay for the premiums for old uninsured people. And my argument all along, from 2010 to today, has been that doesn't make any sense. If we want to help people with pre-existing conditions, the near elderly, to afford health insurance, we shouldn't punish healthy and young people who are also uninsured and also struggling to afford health insurance. We should, as a country, as 330 million of us, we should share that burden together instead of concentrating it on the 10 to 20 million or 30 million Americans who are healthy and or young, who struggle also to afford health insurance. Why should we make them pay more? The ACA solution was, well, we'll just have an individual mandate that forces everyone to buy insurance and we'll subsidize it for a certain population. And my belief then and now is that those legs of the three-legged stool were not robust enough to achieve the desired result. And I think I've been proven right about that. And so as that's the background for the proposal is, let's tackle those two problems. Let's tackle the problem of the sick, the healthy being overcharged to pay for the sick by having what insurance pros called reinsurance. The ACA had that for 3 years temporarily, and then it phased out. Republicans like to call it invisible high-risk pools. Pick your terminology.
We almost had it, too.
It's basically the same thing. Yeah.
Well, I know, but I mean, it almost passed.
It almost passed. That's right. So this is something that legislators in Congress are pretty familiar with because they've discussed it before. And Pelosi has proposed it. Republicans have proposed it. So this is not a
Susan Collins' big idea.
This is not a particularly partisan idea. But it's something that if you do it, and the way I'd explain it to your listeners is, it's basically we have directly subsidizing the cost of coverage for people with pre-existing conditions and the sick. So instead of making healthy uninsured people have triple the premiums for that purpose, you basically say all 330 million of us are going to pay a little bit more in taxes or what have you, or just part of our taxes that we already pay. We'll fund that reinsurance, which will lop off, let's say, the sickest 10% of the people on the back end. So you won't have to sign up separately for the high-risk pool, which was an old Republican idea. It's all done on the back end in an integrated way, which I think is much better, much more efficient, allows you to really capture those high-cost and high-risk patients. And that way,
as you point out, completely bipartisan.
Completely bipartisan. And the beauty of it is by subsidizing the cost directly of the sick people, the premiums for everybody else can go down in compensation. In fact, actuaries believe that for every dollar you spend on reinsurance, you get somewhere between 50 and 80% back in the form of lower premiums. That then mean, again, it costs less to subsidize the ACA, right? So if the whole debate is, why should we spend more subsidizing the ACA if you're a Republican, because it's not our fault that the premiums are going up. We didn't vote for this bill, right? Then you should be in favor of lowering the premium. So one idea, as I said, is to fix this problem of the sick versus the healthy in the ACA. And then the other piece of it is the young versus the old. So if you talk to insurers, what they'll tell you is that the average young person who buys insurance, let's call it a 27-year-old, consumes about 1/5 the amount of health care in dollar terms that a 64-year-old consumes. And so insurers would normally say, okay, that means that the 27-year-old's premium should be 1/5 of the 64-year-old's because they're consuming 1/5 of the health care. The idea of the ACA was, no, you young people should pay more to help pay for the cost of the older people. But basically, if you overcharge the young people, they all drop out. And then you have the adverse selection death spiral. So how do you fix that? And by the way, the other thing I would say is that if you talk to insurers or actuaries, what they'll tell you is that 3/4 of the variation in premiums, if you were to simply charge people what you think their actual individual health risk is, if you were to say, what's the variation in health costs between this 1,000 people or 10,000 people that get insurance, they would say 3/4 of it is age-based, meaning if you just allow insurers to price insurance fairly by age, you solve a lot of the problem of adverse selection because younger people are generally healthier than older people.
Then do you have to more heavily subsidize the older people?
Not necessarily. So my argument would be you don't have to, because when you bring those healthy people back into the market, premiums go down for everybody because the premiums are driven by the average cost of the average person in the pool. Having said that, precisely because that is a fear that people have, part of our proposal is to age adjust the ACA tax credits to protect against that very risk, right? So for those who aren't convinced by my spiel that young people would come back in the market and everything would work out wonderfully, we sort of have a backstop or a guardrail where we say, okay, let's take the ACA subsidies right now. They're adjusted purely by income, and say, let's make it a 2D table. So instead of just being adjusted by income, you're also adjusting by age, so that those near elderly people in their early 60s or late 50s, you can guarantee that they won't have increased premiums.
So bottom line, there are ways to address this.
Absolutely, and so the pitch I'm trying to make to the Republicans who say, well, let the enhanced subsidies expire. What do we care? It's not our fault. Again, my argument to them is like, look, you've been criticizing the ACA for how it overregulates insurance and makes insurance too expensive. That's something that Republicans have been saying for a long time, and I agree with them. Broadly speaking, I do think a certain amount of regulation is appropriate, but there are certain regulations that weren't designed well, the ones we've talked about. And so my pitch to the Republicans is, look, you need 60 votes. If there's one thing you should have learned in 2017, it's that you need 60 votes in the Senate, so long as there's a filibuster. And I know, there's always some people who say, get rid of the filibuster. But so long as we have it, and leading Republicans still believe we should have it, if you still believe in a filibuster, then you need 60 votes, 6-0, in the Senate to reform these regulations. And if you're going to get 60 votes in the Senate, that means you have to appeal to at least some Democrats. You don't have to appeal to all of them. Right now, the Senate's 52-48, which means you have to get 8 out of the 48 Democrats, 1/6 of the Democrats to go along with your idea. That seems like it's doable, but it requires Republicans to be willing to listen and hear out their friends on the other side and see what they might want. And my hope is that something like this could meet that standard.
Well, we're back in the thick of it, Avik Roy. Hope we can have you back again.
Thanks, Julie. I love it.